who is going to be our last speaker, Dr. Soumya, and she's going to be talking about when thyroid is the culprit.
Good morning. So this is a very common presentation of generalized lid swelling which comes to our OPD, but this will stand out with the lid retraction and lateral flare, lid lag, periorbital fullness and the staring look. Also look for the extraocular motility disorders, congenital congestion, superior limbic keratoconjunctivitis, and we should look for compressive optic neuropathy. So here thyroid is the culprit. So thyroid eye disease is an autoimmune disorder affecting the orbit in the third and fifth decade of life with female preponderance, and 90% of patients are hyperthyroids. And this is the pathogenesis. The orbital fibroblast is the effector cell where it has insulin growth factor receptors and thyroid stimulating hormone receptor, where the corresponding antibodies will come and attack, and there will be increased glycosaminoglycose production, adipogenesis, and fibromyoblast proliferation, which leads to all the symptoms and signs of thyroid eye disease. So for evaluation, we should do complete ocular evaluation, including diplopia charting and visual fields. We should do thyroid function test, including TPO and thyroglobulin antibody. We have to rule out other autoimmune disorders like myasthenia gravis. The imaging is also very important. In CT is the most common investigation we do. In that, we should check for fat hypertrophy, muscle enlargement, which is shown with the red arrow. Radiological activity we should check, that is seen with the inflammatory edema. We should also check for apical crowding, that is the effacement of the perineural fat by the muscles. We should also look for Barrett's index, that is either horizontal index or vertical index. In vertical index, we'll add the vertical recti muscle thickness divided by the vertical orbit diameter and into 100. And if it is more than 67%, it's suggestive of apical crowding. So now we have a clinical diagnosis which is confirmed with a radiological signs. So now it's time for treatment. So what is the aim of our treatment? This is the Rendell's curve which shows the natural course of the thyroid eye disease. It has an active phase and a quiescent phase. In active phase, if we start early the treatment, the morbidity will be less. So the two things we have to check in these patients are whether the patient is active or in the quiescent stage, and also about the severity. For activity, we can use the clinical activity score. We will have 7, we have to check the patient in the first visit and also in the follow-up visit. These 7 points like pain, swelling and redness of the conjunctiva and eyelids should be checked, and each given a 1 point score. And if the score is more than 3 out of 7 in the first visit and more than 4 out of 10 in the follow-up visit, we will consider it to be active disease. So the severity is defined by UGOGO, that is mild if there is minimal lid retraction and minimal extraocular muscle motility defects, and moderate to severe if there is profuse proptosis and if there is extensive extraocular motility disorder, and if it's sight-threatening, if it is dysthyroid optic neuropathy and corneal exposure. So this is a nutshell of the treatment of active thyroid eye disease. If it is mild, we'll stick into the conservative management with lubricant. Sometimes we may require oral steroids. And in case of moderate to severe thyroid eye disease, we have to start low-dose IVMP therapy. If there is suboptimal response, we have to go for low-dose radiation along with steroids. And also we can go for immunomodulators. And in case of severe sight-threatening disease, we should give high-dose IVMP therapy. If there is suboptimal response, we have to go for early endonasal decompression, endoscopic decompression. So by UGOGO, they have also mentioned, along with steroids, in case of moderate to severe thyroid eye disease, we can start mycophenol mofetil. And in case methylprednisolone is the primary line of treatment, we can give as an intermediate IVMP therapy with 500 mg per week for 6 weeks, then reduce to 250 mg per week for 6 weeks, or high dose we can even start with 750 mg and reduce to 500 mg. And in case of dysthyroid optic neuropathy, we have to give 1 gram IVMP dose for 3 days, and then we have to shift into the weekly regime. So we can also give immunomodulators like mycophenol mofetil, cyclosporin, azathioprine and methotrexate. And there is targeted therapies evolving, and orbital radiation like 20 Gay in 10 divided doses over 2 weeks of time can be given. And this is a surgical management, it's a rehabilitatory management for the inactive cases. First we have to do orbital decompression, then if needed, and wait for it to settle and then do extraocular muscle surgeries and wait and then do the lid correction surgeries. Thank you.
Thank you, Dr. Soumya. I think that was a fabulous IC.